Yeah, so don't worry, this is not going to be a pep talk about how we should all be nicer, and it's not a sales pitch for Press Ganey products. This is really a strategy discussion. And I am a clinician by training, and my introduction to strategy really came on the job. And I'll tell you that story because it was like 2004, and my job at that time was integrating care at Partners Healthcare System, the delivery system founded by the Brigham and Mass General. And we heard at that time that Michael Porter, the Harvard Business School professor, was out there saying Partners was not really an integrated delivery system. And we thought, that's not very good. And so we asked him to come over to have lunch with me and my boss, the CEO of Partners at that time, Jim Mongan. And I told him all the wonderful things we were doing, spreading electronic medical records, decision support, feeding back data, this kind of thing. And he was nice and he was respectful, but he finally went, that's all very lovely. And that's the day I learned that when someone says lovely in a business context, it's not good, because what's coming next is you don't want to hear. He goes, that's all very lovely. He says, but it's not the same as organizing care around patients. And as soon as he said that, I knew he was right. I knew that, the way I was looking at the world had to change. And I tell you this because I'm hoping that this sets the stage for the panel to follow on patient-centered care in the future. And so I said to him, what would you do if you were us? And he basically invited me to come over to his office, and we started what's become a 15-year relationship in which we've written a number of things together. And I'm going to just sort of highlight 3 messages from 3 things that Mike and I have written about together. The first is, we wrote this article a couple years ago, 3 years ago now, I guess, 4 years ago now, called Why Strategy Matters Now. And that came out of a comment that he made that healthcare organizations haven't really needed strategy until recently. And as we talked about that, we ended up writing that article, and the point we wanted to make in there was the difference between strategy and operational effectiveness. And I know a lot of you in this audience have much deeper insights into strategy than I do, so this is very, very basic, but it was new for me. And operational effectiveness is really, really important. It's doing a better job of what we currently do, and that's a lot of work. It's learning best practices from others. It's taking waste and unreliability out of the system. It's attracting and retaining good people. It's working really hard. It's tremendous, honorable work. And in the period at the beginning of my career, like up until the turn of the century, operational effectiveness was enough. If you worked hard and did a good job and you had a good brand, you could get enough people in the door and you could negotiate for what you needed to have a decent margin, and life could go on. But because of a variety of issues, tremendous progress, rising costs, Balanced Budget Act, that's no longer enough. It's still essential, but it's not enough to thrive. It's enough to survive. And if you're going to thrive, the point Mike was making that day is now you need strategy, where strategy is about choices about what you'll do. And those choices should be guided by 2 key questions. And this is in the article. We say strategy boils down to 2 simple questions. What are we trying to do for whom? Who's the customer and how are you creating value for the customer? And then how are we going to be different? What's your competitive differentiator? So Mike and I both feel that operational effectiveness is 90% of management. And if you don't have good operational effectiveness, you might as well close up shop. You can have the most brilliant strategy in the world, but you're not going to be able to compete. You've got to have good operational effectiveness. But to thrive, you have to be ready to make choices these days, focus on customers, create value, and differentiating value. So to do that, to create a framework for doing that, Mike and I wrote this piece together in 2013 in Harvard Business Review. And one of the reasons I wanted to show it here today is because, the idea of what a framework is I think it's interesting. And it comes out, what I'll describe for you is what Mike would say about how he started thinking in terms of frameworks. Goes back to when he was a student in the 80s, when he was getting a PhD in economics, doing traditional academic work, exposure A, outcome B, adjusting for all these different variables. And he was also getting an MBA at Harvard Business School, studying lots of cases, visiting companies. And he felt that they were both interesting types of learning, but they weren't really helping him for the question that he wanted to answer, which is, what should the CEO do? The academic type of learning, it was too simple. It was interesting, but it didn't tell you what to do. And the traditional MBA type of learning, where you would read about how people handle crises, that was interesting. It helped him learn judgment. But judgment is not the same as knowing what to do. And that's when he started thinking about strategic frameworks like the 5 forces and stuff, ways of thinking of multiple intertwined factors, and that could be robust enough to provide a path forward. So we wrote this piece in 2013 with like 5 factors with IT running across it. And I'm not going to go into them, but except that, the first 3 are organized into integrated practice units, real teams that measure outcomes and costs that really matter to patients, moving toward incentive systems that actually reward value. The key point, though, is to make these that they're intertwined. You can't just do any one thing and expect anything to happen. You have to be ready to do multiple things, and then something is likely to happen. And thinking about, there are no magic bullets in healthcare because our problems are too complex. We have to be ready to do multiple things at multiple levels if we're going to have action. So for the last part of my talk, though, I want to turn to this IPU thing. Actually, maybe I don't know if I can go back. This phrase IPU, this is Integrated Practice Unit, this is a phrase that Mike came up with for his 2004 book. And Mike loves that phrase. No one else likes that phrase. Everyone else just wants to say team. And I will spend a lot of time with him, and I'll say team, and he'll stop me and he'll go, Integrated Practice Unit. And I'll go, Integrated Practice Unit. And so finally, one Sunday, we were sitting around and said, Mike, why do you make everyone say Integrated Practice Unit? It takes longer than saying team. And why? No one else wants to do it. And he goes, well, it reminds me of SBU. And I go, what's an SBU? You're making everyone else say IPUs because it reminds you of something else, and no one even knows that's going on, and no one knows what an SBU is. And he goes, well, kind of. But he goes, but there's a point to it. And that's when we had this discussion that led to this article, which we wrote in a year ago in NEJM Catalyst. It's about what 21st century business has to learn from 20th century, healthcare has to learn from 20th century business. And we talked about how a century ago, US business was undergoing organizational change that led to huge improvements in performance. And the old model of business had been organized around functions like manufacturing, sales, and marketing. But that was an era like the 19th century where the products were simple and the customers were simple and you didn't move things over big, long distances. But toward the end of the 19th century, there was this wave of innovation, creativity, Thomas Edison, Alexander Graham Bell, but then incredible engineering advances beneath, that's less spectacular, enabling mass production of complex products and movement across great distances. The result was that companies got bigger and they started making more complex products for multiple types of customers. And so that by the end of World War I, one of my favorite examples was DuPont. DuPont had gone from being a little chemical company to making gunpowder for the war effort and automobile tires for the auto industry, which was taking off, and nylon stockings, because now they could make nylon stockings, and it was the Roaring '20s, and people wanted to party. And they were trying to marketing explosives and nylon stockings, and it was very hard for them to do a good job with all those different customer bases. So they and other companies started to evolve their management structure and into strategic business units. The phrase was used at General Electric for the first time in 1973, and then became much more commonly used. GE Aircraft, GE Power, and so on. And within each SBU, they function like independent businesses with the profits, the costs, and the revenue and the costs. And one of the insights was that when you don't know what your costs really are, when costs are spread across everyone, then the only way you can improve is try to bring in more revenue, and which is what we do in healthcare. We just try to bring in more volume as opposed to try to improve performance, improve efficiency, within some definable unit where we know what things actually cost and what our outcomes are. So this is my last slide. This is why we think that healthcare today is where business was 100 years ago. We're still kind of organized around the functions, what we do, what doctors do, surgery, medicine, radiology. It reflects medical science as opposed to the needs of patients, and it's reinforced by the fee-for-service system. And the teams are loosely organized pickup teams. But the structure is changing analogous to the ways that business changed a century ago. High-volume institutions are co-locating key personnel. They're measuring outcomes, they're negotiating bundles, and they're making the changes even before the contracting models have changed because the care is just too chaotic if it's organized around us as opposed to patients. So I'm hoping that we'll get some of the answers to how this change is going to happen with our next panel. Thanks very much.